this morning. This is the fourth meeting of the Budget Review Subcommittee on Health and Family Services. As a reminder, there is no remote attendance for members that is permitted, and we have put all the meeting materials online and available for download. At this time, we'll have the secretary call the roll. Thank you.
Senator Berg. Senator Titchener. Representative Duval.
Here.
Representative Fleming. Representative Johnson. Representative Raymer. Representative Wilner.
Here.
Representative Wilson. Senator Mays Bledsoe. Senator McDaniel. Senator Meredith. Representative Bowling. Representative Bray. Representative Heverin. Representative Poor Moser. Representative Petrie. Representative Williams. Chair Richardson.
Let me turn my microphone on before I tell others to turn their microphone on. Thank you. First presentation this morning, we have Adam Mather with KAHCF. That's a mouthful. Raquel Reynolds with Elder Care Partners, and Joe Jurgensen with Management Systems of Kentucky. They'll provide us an overview of personal care homes. Please just introduce yourselves. Make sure the green light's on when you speak. And for the members, please hold your questions to the end.
You'll be happy to know we are rebranding, so it'll be easier to say. Yes. Well, thank you so much. We're really pleased to be here today. My name's Adam Mather with the Kentucky Association of Healthcare Facilities. I'm the president of the association. I'll allow my other colleagues to introduce themselves.
My name's
Are you on? There you go.
My name's Joe Jurgensen. I work for a company called Management Systems of Kentucky, and we own and operate personal care homes in the state as well as assisted living facilities.
Hi, good morning. I'm Raquel Reynolds. I'm the COO of Elder Care Partners, and we own personal care homes in the state of Kentucky.
Great. I'll go ahead and get started. Again, thank you all for allowing us to speak. Kentucky personal care homes are the safety net for adults, often with serious mental illness who do not qualify for other programs but still need stable, staffed homes in Kentucky. For about $50 a day, these homes deliver housing, round-the-clock staffing, medication assistance, 3 meals, therapeutic diets, hygiene, laundry, activities, and housekeeping. That bundle is no longer sustainable at today's rates. As you can see, these facilities were established around during the 1970s, in 2013, there were around 81 personal care facilities serving 4,400 Kentuckians. Today, through attrition, because of the current rates, we have less than half of those facilities and beds still remaining in operation. And as I stated before, the rates currently no longer cover the basic needs for those residents. In addition, there are ever-growing costs associated with the care of these individuals, and not only that, just the sustaining of the operations in regards to the cost of insurance. The cost of insurance has gone up exponentially over the years to cover the personal care homes. So a little history on personal care homes, who we serve. These are adults with serious mental illness that need supervised and structured care. These are not a nursing home setting. These are much lower care settings. They don't require intensive care. They will occasionally need an acute care setting, but the sustained care that they need does not require a heavy setting for them. Specialized personal care homes house people with mental illness, intellectual disabilities, and they have additional requirements. the stakes are not only human but fiscal, as well as given that many other care settings are not as therapeutic for these. We did find one individual that would have been appropriate for this setting, and they spent 13 months in an acute care hospital. So you can imagine how untherapeutic that was for that individual. That would have been appropriate for this setting. One of the big takeaways for this is that these residents really do not meet nursing home criteria. So if they were put in a nursing home, they would not meet level of care. Personal care homes are just so how they are regulated. They are regulated by the Cabinet for Health and Family Services through the Office of Inspector General, and those regulations are established under the KRS and through the administrative regulations. And just to share with you how those are funded. So many PCH residents are extremely low income and they rely on state supplementation payment. So how that functions is they typically will receive Social Security income or disability, and then general funds offset whatever that is to make up the difference for that payment, so that the facility receives approximately $50.07 a day to make up that payment for them. And then they do receive a monthly allowance as well, so they have some personal income that they can use for their own items as well. Just to reiterate what these homes provide, they provide staffing and daily resident supports. They do not use Medicaid funds. I just want to make that abundantly clear. The personal care homes offer a much lower cost alternative to emergency rooms, long-term acute care hospital stays, jails, psychiatric admissions in acute care psychiatric facilities, and nursing homes, which really are higher levels of care than these people really qualify for. And every retained PCH bed really does protect residents' families and our local systems, because those beds ensure that we have beds at the appropriate care settings for those individuals that really need them when the time comes. And why are we talking to you now about these? Because I think we've seen such attrition in the number of beds. We've seen such a rise in the cost of care for personal care individuals that now is the time that we need to come and talk to you about this and educate you on the issue, because we've reached that, I think, that critical point where we're seeing, and that's why I've brought some of our providers here to share with you their stories, because we're seeing that point where $50 a day just is not covering the cost of care anymore. We're on the verge of a lot of facilities closing. We're not seeing a shortage of these individuals that need the care, and so we're really at that critical point where we need something to be done. And so I want to let Joe share some of his personal perspectives with you. He's an operator in Kentucky, and he can.
I got it.
Thank you.
Thank you, Adam. And I apologize for repeating anything that Adam just said, but it's probably worth repeating. Thank you for everyone on this committee for allowing us to talk today about personal care homes. Our Kentucky personal care homes are the state's largest provider of 24/7, 365 care to Kentuckians with serious mental illness. These are home-like facilities that are in communities around the state, often located within residential neighborhoods. The homes and their staff provide a plethora of services to the individuals who live in them. Services include 3 daily nutritious meals, 3 daily snacks. We provide medication technicians to assist residents taking their daily prescribed medications. We arrange for all doctor's appointments, specialists, lab work, pharmacy fills, daily activities, transportation, laundry, housekeeping. We provide all personal hygiene products, furniture, clothing, annual vaccines, and assistance with ADLs. And for many of our residents, our staff is their only family and their only support system. The homes provide everything we need to keep the residents out of the hospital, homeless shelters, nursing homes, or the jail system. When I started in 2002, we had 64 personal care homes that cared for the seriously mentally ill. And just to clarify, Adam's number of 81, that included private pay personal care homes, private pay assisted living facilities that chose to get a a personal care license. All those homes have been transitioned to assisted living licenses as of now. So in 2002, we had 64 personal care homes that cared for the seriously mentally ill, and the daily rate was $31.03. Fast forward 23 years, we currently have 34 homes left, and the daily rate's $50.07 a day. The rate's gone up $19 in 23 years, and 30 personal care homes have had to shut their doors. I don't think it's a coincidence that in losing 30 personal care homes and continually denying mental illness treatment, that our homeless population has exploded over the past 23 years. As noted, the current monthly rate is set by the cabinet is $50.07 a day. The state spends on average $6,672 per person each year to live in a personal care home. It only takes about 5 to 6 days in any one of our state psychiatric hospitals to achieve the same cost, and that is where we get a lot of the individuals from discharged from those hospitals. The average size of the homes is 61 beds. Ours are 32 and 40. The individuals living in these homes rely on 24/7 structured care because they can't survive independently in the community without it. I want to quote the late Justice Ruth Bader Ginsburg when speaking about the Americans with Disability Act. She said, "We emphasize that nothing in the Americans with Disability Act or its implementing regulation condones termination of institutional settings for persons unable to handle or benefit from community settings." She is referring to the exact population that lives in our Kentucky personal care homes. And the Supreme Court justices all recognize that there is a segment of our population that requires institutional care in order to live as independently as possible. The good news is that institutional care can be provided in smaller, non-hospital settings with dignity afforded to the individual and beneficial outcomes. The individuals living in these homes range in age from 18 into their 80s. Most of them draw an SSI check for their mental disability, which they turn over to help pay for approximately 63% of their monthly room and board. The state of Kentucky supplements the other 36% on average out of our general funds via the state supplementation program. It must be noted that the personal care home program is not part of Medicaid, even though nearly everyone living in them is a Medicaid consumer. Most of the individuals do have a serious mental illness with diagnosis of paranoid schizophrenia, bipolar, personality disorders, and other life-afflicting diagnoses. Per our regulations, all the individuals are free to come and go as they please, and we are to encourage them to leave the premises. This is a level of care that allows for a lot of freedom while also providing oversight and care around the clock. It's not jail nor a lockdown psychiatric unit. We have countless examples of admitting somebody who's been a frequent flyer in and out of Eastern, Western, Central State, or multiple hospitals around the state. Many times, but have lived with us for many years and have had no hospitalizations. The reason being we ensure they take their daily prescribed medications, feed them nutritious meals, and have oversight around the clock to deal with illness, injury, lab work, and any medical or psychiatric issue that arises. We nip stuff in the bud to prevent hospitalization and other more costly outcomes to the best of our ability. The cost savings to the state and society that these handful of personal care homes save is significant. Just one example, we recently admitted a gentleman at our facility in Allen County who had spent 14 months in a Lexington hospital. We admitted him in June. He's coming on his 3rd month here in about a week, and all has been well so far. He's eating well, he's socializing, taking his medication, seeing his doctor, and most importantly, has stayed out of the hospital. There's no guarantee that he'll stay out, but we are certainly giving him the best opportunity to. And he got out of that hospital and back into the community via the personal care home continuum of care. In summary, we must stop the closing of these homes and ensure Kentuckians with serious mental illness who can't live independently in the community have a place they can call home and live their life to the fullest. We don't need more homes shutting down and contributing to our overcrowded homeless population and limited psychiatric hospital beds. Kentucky is unique in that we have the personal care homes to help care for this population, but we must support the individuals in the homes they live in. Our current situation is better than it could be, but we have a lot of room for improvement. In fact, we've been proposing an assisted living for the mentally ill model for some time. We just need the support. I thank you all again, and I'm open to any questions.
Turn it over to Raquel.
Thank you, Joe. Good morning. First and foremost, I wanted to thank you for your time this morning and for allowing us. Oh, I'm sorry. First and foremost, I wanted to thank you for your time this morning and for allowing us to share with you what it is we do and, most importantly, who we care for. As owners of 16 personal care homes in the state of Kentucky, we're grateful every day for the opportunity that we have to be able to give our residents a second, sometimes a third, and even a fourth chance at life. We first entered the state of Kentucky in March 2022. We began with 3 personal care homes and a lease on the 4th, and from July 2023 through present, we had acquired the rest. As Joe mentioned, we currently receive $15.23 a month for each resident that we serve. That amount is meant to cover all our expenses: food, payroll, insurance, maintenance, utilities, and the many unexpected expenses that come with caring for people and maintaining their homes. Since we've entered the state, we have invested over $800,000 on capital improvements to ensure that our residents have places they are proud to call home. Many of the facilities that we had purchased were in immediate need of significant updates and repairs. As an example, in one of our facilities on the day of closing, we found out that the HVAC and electrical systems were inoperative. We therefore spent $112,000 to make the building safe and functional before we had even officially taken ownership. Other locations required 6-figure investments within the first year and a half just to make them comfortable, safe, and welcoming for our residents. These investments weren't optional. They were necessary to ensure that our residents live with dignity, safety, and warmth. As I'm sure you can imagine, the $15.23 a month we're granted doesn't reflect the true cost of providing this level of care and a home environment for our residents. Our staff make this possible. They do not see this as a workplace, but as a resident's home. They treat each resident like family because ultimately that is exactly what they are for our residents. We have also raised wages significantly at some of our homes by 24% for new hires and more than 27% for existing staff, because our caregivers deserve to be paid in a way that reflects the immense responsibility and compassion they bring to their work. At the same time, costs for food, supplies, and utilities have risen dramatically, on average about 35%, while our reimbursement rates have increased only 23.7% over more than 2 decades. Liability insurance, which is a critically important, extraordinarily expensive, is simply out of reach for many of our operators under the current structure. It's important to understand that this is not about profit, it's about stability and survival. There have been 30 PCH closures over the past 23 years, 2 of which have happened since August. Each closure displaces vulnerable Kentuckians who rely on us for shelter, meals, medication management, and community. These homes are often the last safety net before homelessness. To put it in perspective, we receive $50.07 a day, when operating costs per resident can total between $42 and $45 a day. The few dollars of margin that might exist are quickly consumed by overtime, mortgage payments, or unexpected repairs. It's simply not sustainable. Unfortunately, with the reimbursement as it is, it's not possible for personal care home owners to continue operating. If personal care homes are forced to close, thousands of vulnerable individuals will have nowhere to go, and that's not the outcome that any of us want to see. We welcome you to visit any of our homes and meet the individuals that we serve. Seeing their smiles, hearing their stories, and understanding their journeys is the best way to understand why we do this work and why it matters so deeply. I sincerely appreciate your time today. Thank you.
Thank you so much to all 3 of you. I appreciate what you do in the space that you stand in. I have one question. I think we've got a few questions from some members. And Adam, and I'm just kind of going on your first slide there. In 2013, you had 81 personal care homes. Several, I think over 30 have closed down too, just in August. You said you were serving 4,400 at that time. Is that right? That's that 4,400 number? And this might be a hard question. Yeah. I don't know. What is the number, not how many you're serving now, but that need to be served? And I know that's a hard number. I'm not going to hold you to it. I'm just, for my curiosity's sake, just sort of want to know what's the number out there, roughly.
I'll let Joe take that.
We're currently serving around 2,000 in the homes today. To get to your number, the best I could do is we probably will admit 1 person for every 30 referrals that we receive from guardianship, from any of the state psychiatric hospitals, any of the hospitals in Lexington or Louisville. 30 referrals for one person that's appropriate for our level of care. So those other 29, they're sick beyond even our level of care, and we are used to caring for some sick individuals. I don't know what that number is.
Yeah.
And the 4,000, then I think that it's contributed to our homeless situation. They've been displaced. There's a whole another level out there. And I know we used to send some up to Ohio when we couldn't find placement for them anymore.
Yeah, I think it would be hard for us to
Yeah.
give you a figure, but I would imagine that and I appreciate you not holding us to that, but I would imagine that it has not gone down from those original numbers, just given
I would imagine that. Just
population.
one follow-up, if I may, and then I'll turn the time over to the members here. Back to your Allen County, Mr. Jurgensen, your Allen County, was that you? Is
Yes.
that right?
Yeah.
Your Allen County example, how did that referral process happen to come to you in the first place from being in the hospital for, I think, 13 months?
14 months.
14 months.
14 months, almost to the day. It came via guardianship services.
Okay.
And they had been trying to place them for over a year to any facility that would take them. No one would take them for specific behaviors. And we did our homework, and we rolled the dice, so to speak, and admitted him. And 3 months in, he's doing good.
Good on
he
you.
stayed out of that hospital.
Thank you. We'll start with Representative Duval.
Thank you, Chair. And thank you for the work that you're doing. This is crucially important, and we do have an obligation to provide for the most vulnerable among us. And so I'm thankful for the work that you're doing. My question is around staffing credentialing. Are there any credentialing processes for the staff at these facilities?
There's no requirement for any licensed or certified staff in these facilities. My assumption's always been it goes back to the reimbursement, and the state realized with the reimbursement we get that they could not put staffing requirements on these PC homes. We do have certified medication technicians when we're lucky enough. One of our administrators happens to be an LPN, which is a rarity, but we've retained her for 23 years now in that role. So part of our vision is to enhance the program, enhance reimbursement, but also enhance staffing requirements and regulations and the structure to, again, I feel these homes in the future can serve a 50-50 purpose. They can serve 50% of the people that will always need that institutional level of care. The other 50% could be a revolving door, like a rehab. So you come out of Eastern State or Central State, you go to that personal care home, you learn the skills to manage your money, your medication, your ADLs, housekeeping. When you're ready to go, then you go out into the community and do an individual apartment and have at. Right now, we're putting people in apartments that do not have the skills necessarily, and they are failing left and right.
Well, appreciate the work, and I'm certainly interested in helping because this is very important work. So thank you.
Thank you.
Next, Senator Meredith.
Thank you, Mr. Chair. And Adam, maybe I missed it, but what's the ask going to be? What kind of increase are you looking for?
So we are looking for a incremental increase over the next 2 years. So it would be a 50% increase over the first fiscal year, and then another 50% increase after that.
So Jim tells me we're spending about $12 million a year on this program already. So we're going up to 15. Eventually we'll go to 24 for discussion purposes. And I'm quite convinced that that increase can pay for itself. But here's kind of the problem. And all of us are going to be impacted this as we go in this budget cycle. First, I think we have to have concurrence, an agreement, total agreement, universal agreement that there's enough money in the system already to take care of everybody if we spend it the right way. And I'll share a quick story with you. I think it was 2 budget cycles ago, we had a request to hire 200 more social workers. And if we did, it would save us like $200 million. It's a great return on investment. Now, where's the savings? And when I ask the question, they go, what do you mean? Well, you said if we hire 200, we can save $200 million. Where's the savings? Had to ask the question 3 times. And finally, someone said, well, it's kind of absorbed in the system. And that's the point I want to make here. We know that we used to house 4,000, now we're 2,000. Where are those other 2,000?
They're currently in higher levels of care that cost more money.
Exactly.
So,
And
exactly.
if we open this up, we can move them out. But unless we reflect that true savings in our budgeting process, we haven't saved anything. So if we can identify that maybe they're in jail, and that's costing us, discussion purposes, $2 million, then we should reduce that appropriation by $2 million. Same with Medicaid. I think we can save Medicaid dollars, but only if we reduce the Medicaid corresponding spending over here. So that's a dilemma we have to have, and maybe it needs to be a special budget line item that says we do this, but over here is the corresponding offset in cost. So that's a challenge, but we have to do that. We can't continue to say, and we're going to hear presentations from hundreds of people between now and budget time, that if we do this, we'll save this, but we never realize those savings.
Sure.
And we have to. So again, I would support this, but we need some real strong documentation of where those savings come from, and we need to make corresponding adjustments to do that. So thank you, Mr. Chair.
Thank you. Representative Fleming.
Thank you, Mr. Chair. I just want to, first of all, echo the Senator Emeritus' comment. And you know, Adam, we're trying to find money in order
Absolutely.
to look at reimbursements, because that's I'm hearing time in and time out. And you all are not any different in terms of trying to do what we can to help y'all out. So let you know that we're going to go for the process and try to find whatever we can to find out. But we got to have justification to go through. And I think you know that. Is it Raquel? I just want to ask you a question. You mentioned, I think you have like 12, 13 facilities in Kentucky. I assume
16.
you might have other facilities in other parts of the country.
Yeah.
Could you give me a comparison of what goes on in those other parts of your operations in other states compared
Sure.
to what we're doing here?
Sure.
Thank you.
So in the other states that we're in, it's more of a care model based on the residents' needs. So, for example, I'll use Minnesota as an example.
I'm sorry. When you say care model, is that
So it's
is that
based on
an ACO?
No, it's based on the residents' care needs.
Oh, okay.
So the way it works, and I'm going to use Minnesota as an example. It's easy to explain, I think. So in Kentucky, we have a flat rate. We get $15.23 a month, whatever the resident needs, and that includes those that have high level of behaviors. That's covered within the $15.23 a month. In Minnesota, for example, we take the same type of clientele, meaning they have various mental health illnesses. Usually they have multiple diagnoses, and they also have a high level of ADL needs, activities of daily living, so dressing, grooming, bathing, things like that, which the ADL portion we do not take in personal care homes. It's not within the regulation. But the behavioral needs are comparable. The difference is that in Minnesota, you can take an individual that has a very high level of behavioral needs, because when you get reimbursed, it's individualized. So if an individual, let's say, needs somebody to sit with them for an hour a day to talk through things, or they have suicidal ideations, and then your staff is going to spend a half hour with them, calming them down, because that's what the person needs. The person doesn't need to go out to the hospital. The person needs somebody that cares about them and that listens. And that's what we see with a lot of our residents. And we see that in Kentucky also. They don't have family, so we are their family. So many of our residents just need somebody to sit down and show them that they care. And we get reimbursed based on, let's say, that half hour that they need. You could have another resident, though, in the building that doesn't need that, and they have very low behaviors. They may get agitated, here and there. The staff may have to calm them down every so often, but it's not a daily thing. It can happen 3 times a week. Your reimbursement is going to be different for those 2 individuals, and that allows us as operators to staff accordingly. So, for example, in Minnesota, where we have individuals that really do need that one-on-one time. Some have it 30 minutes a day, 3 times a week. Some of them have 30 minutes a day, 7 days a week. But we have people on staff that their only job is to speak to those residents. Or if they see that a behavior is escalating, their only job is to go and go off. They have relationships with these residents. So go and speak to them and calm them down. Let's figure out what's really going on. Why did this resident really get triggered? And with that, we avoid hospitalizations all the time. Every single day, we avoid hospitalizations because we're able to put that resource in for our residents. Whereas in Kentucky, we're not able to because we have a reimbursement, a flat reimbursement, and you have all your costs have to fit into that reimbursement. Does that answer your question?
It does, and
Okay.
I do appreciate. So, in summary, what you're telling me, you basically personalize and customize.
We do.
According to an individual, and not go through a blanket type of approach when it comes to reimbursement process.
Exactly. And there's an approval process, meaning we don't just say, okay, this is what we think that the person needs. You know, they need 5 hours a week of behavioral intervention and that's it. And we just bill for it. That's not how it works at all.
And so that will control any type of fraud because they're
Yeah.
I know your industry doesn't have any bad characters, but I don't know. but obviously, I mean, any organization, you've got to be very mindful of some people or some organizations taking advantage. So is that part of the control of any fraud or any abuse that you might see when you go through a customized type of a process, and who does that oversight?
So the way that it works is that, let's say you have an individual that wants to move into your facility. We get a whole bunch of paperwork. Sometimes it could be 80 pages long if the person's coming from a nursing home. It depends where they're coming from. It's very, very lengthy. Every single resident that would come into this facility has a case manager. So they're familiar with their case, with their needs, with their behaviors. Sometimes you get on the phone with a resident for an assessment, which is done with everybody, and it's actually a state requirement. And, the resident will say, I'm totally independent, right? Because everybody wants to feel independent, but you have a case manager on the phone that knows the person. And the case manager is going to say, well, not really. You need help, with going to the bathroom, for example. We take all that information and we build what's called a rate tool, which is based off of an extremely detailed Excel. So we have an Excel and it will list everything. If we know that somebody has somebody needs help going to the restroom, for example, but they need a lot of help, we'll actually detail that in this Excel that translates to this rate tool, and we submit both of those to the case manager. The case manager is employed by the county. We give it to them. They come back to us and they can either say, this is 100% correct. We've had times where they come back to us and say, well, you only put 30 minutes for this, but I know him and he's really going to need 45 minutes a day. So they'll tell us to change something and we go off of that. That's exactly how we bill. We can't bill till we have a service authorization and the person moves in. Now, what happens if a person has their needs increase? For example, right? They're living with you for 2 years and they're starting to decline. So we follow our residents daily. And if somebody now has a decline and we have to increase their cares, we have to go to the case manager. She's going to say, okay, well, give me the documentation, which we have, and it has to be impeccable because otherwise they're going to tell you no. If in healthcare, if it's not documented, it did not happen. That's the rule of thumb. So you submit your documentation and you'll be like, listen, this is why he needs an increase in, let's say, 1-to-1. And she'll meet with the resident. She'll see, how is he doing? Does she see improvements in certain areas? Does she see he declined? And then she'll take what we submit, assuming she agrees with it and she has no questions, and then she submits that to somebody else within the county for approval. Once that's approved, then we get a service authorization. But we also do the same reversed. If somebody has moved into us and they had very high behavioral needs because they weren't in the right setting, or we took them literally off the streets, it takes them about 2 months to adjust, maybe 3 months sometimes, because they need to adjust to having people that care, having doctors that are coming to see them, having somebody that's encouraging them to take their psych medications every day, because when you're living on the streets, you don't have that. So now let's say 3 months went by and we're like, wow, this gentleman has drastically improved. We will notify the case manager in the same way. So while we notify them for a decline, we also notify them for an improvement. And it doesn't, so our rates do sometimes go down. But what matters for us is that every single resident of ours is looked at as their own person. We don't have two residents that are the same. We don't look at anybody the same. Nobody knows what we're getting paid for anybody. We keep it completely out of the facility because it's nobody's business. They don't know. Their job is to take care of the residents and give them the care that they need.
That's very, very interesting. And one last comment, Mr. Chairman. It'd be interesting to see like a cost comparison of pro forma in terms of the current model and to which y'all are seeing other parts of the states in terms of customizing that, and see if there are any, going back to Senator Meredith's, savings. And I use that word loosely, but it'd be interesting to see what that pro forma would look like in terms of applying that to our situation.
Well,
Thank
I
you,
think
Mr. Chairman.
Acuity-based model,
Sorry.
an acuity-based model.
Yes, sir.
And I think also just on your last point, we get, like Joe said, we get quite a few referrals from those that are in jail and hospitals. That's where most of our referrals come, and homeless shelters. When they move into us, they're with us for usually a very long time because they have stability with us. They don't have that when you're going in and out of a psych hospital or you're going in and out of jail. You're not getting the treatment that you need. But when they're with us, they have true stability. And because we have so many different facilities located throughout the state, we're very fortunate that if somebody's been living with us for, let's say, a year in a given building, and now we see, okay, there's a behavioral change, and we're not sure what it is, oftentimes the resident just needs to change the scenery. And we'll ask the resident, obviously, assuming that they agree, but we move residents to different parts of the state if they would like to, all the time, and we see drastic differences. So it's not that if they're not going to work out, in one facility after X amount of time, sorry, we're discharging you back to the street, or they're going to end up in jail or the hospital. That's not the case at all. We do give our residents other chances in other facilities because a change of scenery, administration, community, it really helps our residents.
Thank you. Just a reminder to our members, we still have 2 more presentations to get through in the next 50 minutes, and I will be ending at 11:59. Our next question is from Senator Titchener.
Thank you. Thank you all for what you do. It's really very important. So with the ask that you have for this budget session, how many more patients can you serve?
Well, we don't have any additional facilities, unfortunately.
What do you project? How do you?
I think we have a 20% occupancy availability, so we would be able to increase by about 20%.
And what does that look for staffing? And I'm kind of trying to figure out if the workforce is
available
and hard to come by.
It is harder to come by. I think with the additional. With the additional budget increase, it'll be easier to get the staffing. And to Representative Duvall's point, they are not certified. So it's really a matter of just getting them trained within the facility. They do individualized training. Obviously, it's a specialized population, and so they do some training on site for them so that they're equipped for that population. But they don't have to go through certifications and things of that nature. So it is a little easier to get, you have a broader group that you can pull from.
Right.
So it has not been as hard as like the skilled or assisted living when you're looking at certified individuals or nurses, for example.
Okay. Thank you.
You got it.
Thank you. Representative Raymer.
Thank you. Senator Titchener had most of my questions. The only other thing I would ask is, you talked about the 30 referrals and that one being appropriate for your level of care. So, with this ask, are you going to be able to serve a higher acuity of patients? And if so, is that regulations that need to be changed for you to take them? Or is it a thing where you were looking at their behaviors and you didn't feel like you had the staff to be able to take care of that patient? And is this going to open that up?
I think the level of care that each home can manage is home to home. So I have one home with an LPN, and she can handle a little bit higher behaviors than my other facility. So not necessarily with increased funding. The increased funding is just going to keep these homes open and keep 2,000 more people out of our homeless shelters at a cost of, according to University of Louisville, $58,000 a year per homeless person, $36,000 a year in Kentucky in the jail system, $6,600 in personal care. But if we could restructure this to my vision in the sky and use it as a turnaround rehab facility, let's revamp the regulations, let's strengthen them.
I would like to have those discussions going forward to see what that would look like and what we could do.
Yeah.
Thank you.
Thank you. Last question before we move on to our next presentation. Senator Berg.
Thank you, guys. Thank you for what you do. Thank you for the space you work in. I have 3 questions. I don't need answers to them. You can give them to me later. 1, do you take people in active addiction? 2, do you ever take referrals directly from the courts? And 3, what type of oversight are you subject to? You can give these to me later, but those are the type of things I would like to know. Thank you.
Thank you, and I'm sure they'll be following up with you, Senator Berg. Thank you so much for all 3 of you for your presentation today.
Thank you so much.
The next item on the agenda this morning is a presentation from Commissioner Lisa Lee and Steve Betchel, the Chief Financial Officer with the Department of Medicaid Services. They'll provide us with a fiscal report for 2025 as we close out, and then an outlook for fiscal year 2026. Please state your name for the record, and members, please hold your brief questions to the end.
Hi. Hello, I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
I'm Steve Bechtel. I'm the Chief Financial Officer for the Department of Medicaid Services.
I'm sorry, wrong presentation.
Escape. There you go. Exit.
Is that one? Yes, that's it. Okay, here we go. As always, we just like to provide a little brief overview of the Medicaid program. Currently, we serve approximately 1.4 million members in Kentucky. Of those 1.4 million members, over 600,000 are children. That's children enrolled in both the Medicaid program and the Kentucky Children's Health Insurance Program. And that 600,000 represents over half of the children in this state. We currently have approximately 450 Medicaid expansion members. Those are members who are between the ages of 18 and 64 who do not qualify for Medicare and who are at 138% of the federal poverty level or below. We have over 69,000 enrolled providers serving our members. That's both in-state and out-of-state providers. And in 2025, our combined administrative and benefits budget was $20.6 billion. This is just our enrollment trend. As you can see, in 2020, we had a little over 1.3 million members. During the COVID period, we saw a huge spike in enrollment. Right prior to 2022, you see a little bit of a drop. That was mainly due to presumptive eligibility individuals. Presumptive eligibility is just a temporary Medicaid benefit for individuals who are waiting on full Medicaid eligibility. During the COVID period between 2020 and 2023, the Department for Medicaid Services received an additional 6.2% enhanced funding from the federal government. Due to us receiving that funding, we could not terminate individuals. In 2023, we began doing redeterminations with the ending of the public health emergency related to COVID. And we have since undergone about two redetermination periods for individuals. A redetermination is just every year. We have to make sure that individuals continue to be eligible for Medicaid, and we go through redetermination periods to make sure that the information that we have is correct. And so you can see as of today, that number is at the little over 1.4 million individuals, which is still higher than the 1.3 million individuals that were enrolled pre-COVID. Would you like to add anything to this, Mr. Bechtel?
You hit on it on the very end. I just want to point out that prior to the pandemic, the public health emergency, we were just above 1.3 million. After the public health emergency ended and all redeterminations, we're now hovering, and you can see we've stabilized for over a year at 1,450,000. So that's about 120 to 150,000 more individuals that we are serving today than what we were prior to the pandemic.
I'll turn this over to our Chief Financial Officer to continue the rest of the presentation.
Yep, thank you. The total expenditures that we spent in 2025, you can see in the benefits, that is $20.3 billion. That's about $115 million more than what was, or less than what was budgeted of the 20.4. So we 0.56%. We came under 1% of meeting the budget. But you can see 0.5% is $115 million. A couple things I want to point out here is for those who are not familiar. I know we may have some new people in this committee. Those who may not be familiar with Medicaid financing is that our state funds are funded through two areas, and that's general fund, which is the General Assembly appropriates. It's about 55% of our state funds. And the other 45 is within restricted agency funds, which we have to support with agency cash. Those cash, the cash is comprised of provider taxes, which is about 20% of the state funds. Intergovernmental transfers from either other state agencies or other governmental agencies, that's about 23% of the state funds. And then now, if you recall, House Bill 695 required us to treat the state share of the drug rebate differently than what has been done historically. The state share or all of the drug rebate is normally a offset of expenditures, but if you recall, House Bill 695 directed us to form a new cash account and to deposit all the state funds of those of the drug rebate into that cash account, which requires us to have restricted fund appropriations to spend. So that's why, if you remember, I testified to this committee that House Bill 695 was going to grow the budget because of that alone. So I just wanted to point that out. That's about 2%. However, that's only 1 quarter in 25 because we only did that effective April, May, and June. So we've only had 1 quarter's worth in the fiscal year 25. So in 26, you'll see a whole year's worth of that. Next slide, please. This pie chart is a breakout that I provide that shows you the between our fee-for-service and our managed care spends. 10% of our population is within the fee-for-service. So 10%, we spend 25% of our budget on services for those 10% of the population. A large portion, you can see by the multicolored pieces of the pie, that is the fee-for-service portion. You can see the majority of that spend is in the long-term care setting. And what I mean by that is nursing facilities. You can see we spent just under $2 billion in 25 on nursing facility expenditures. And alternative community care, we spent just north of $1.9 billion on that. And what is included in alternative community care is your 6 1915C waivers, as well as home health. That's those are the expenditures that's in that piece of the pie. You can see too that if you add those two together, it's about 3.9 billion of the $5 billion that we spent on fee-for-service is in those two areas. The other is managed care. So we have 90% of our population in the managed care setting, and about 75% of our budget is spent in that setting, on services. Now, I will point out the $15.3 billion that's listed here because I have to point this out. That is not just money paid to the MCOs, such as capitation payments to provide services, but it's also state-directed payments that have to be paid through the MCOs. And what I mean by that is it's a pass-through payment. CMS requires us to pay those state-directed payments through our MCOs. I just want to point that out, and we'll go over that more in detail here in a second on a few more slides. This here is a look at the spend from 25 compared to 24, comparing those areas, and you can see the largest increase, we did have a $2.1 billion increase, which is 11.6% increase over 24 in our spend. The largest piece of that increase is in the fee-for-service of $1 billion, which is majority of that, about 78% of that, is tied to nursing facilities and waiver spend. The 6.7% that I mentioned earlier on the managed care side, that is due to directed payments, the growth in state directed payments, the additional directed payments that we've been instructed to do. The other thing on the managed care side is on 1/1 of 25, there was a substantial rate increase for the managed care organizations, and that was due to the acuity levels. We showed you all the graph of the eligibility dropping off. When you look at the overall acuity level of the population today compared to before redeterminations, we have a higher need. The people who dropped off during those redeterminations were your lower utilizers that didn't need the services as much as what we have today. So the ones that we are still serving today, even the 130,000 more people that I told you all about, those are people who are utilizing the program, who have higher needs, higher medical necessities. See, what else was I going to say? So yeah, that's it. Oh, I will say one other thing. The other thing that caused the increase in the rate for managed care is on the pharmacy side. There are some high-cost drugs and some specialty drugs that are hitting the market every day, and they are very expensive. So those are adding to it. Now, what we do in Medicaid, we try to look at what I call it the net effect, which means can we pay the higher name brand drug but get a drug rebate that costs less than if we paid the generic drug. So what we do is we look at our preferred drug listing to make sure that it makes financial sense to pay on the front end the higher cost drug, but on the back end receive those drug rebates to offset that additional cost. Oh, did you already go? I mentioned state-directed payments. So in Kentucky, we have currently four state-directed payments through fiscal year 25. You can see I mentioned too, $15.3 billion was what was paid to and through to the MCOs. Of that 15.3, over $5 billion was paid in directed payments alone in fiscal year 25, which is about a 33% of what we pay to the managed care organizations is actually paid out through a directed payment. We will see this to continue to grow. You can see the growth of this from 2020 to 2025. We will see this continue to grow because if you remember this past session, the legislature passed House Bill 152, which instructed me to do another directed payment for ground ambulance, governmental owned or operated facilities. So that's going to grow this program. The other reason it's going to grow is Kentucky Trauma Hospital rate improvement, which was Senate Bill 280 from 2 sessions ago. We've just paid 1 quarter's payment. So in 26, you're going to see 4 quarters worth of that payment. So you're going to see this to continue to grow in 26 and 27. Now, H.R. 1 put out, that was signed by President on July the 4th, that instructed us to start decreasing those starting in 28. So you will not see that until 28. But that will be a something that we'll have to address in the upcoming budget. Next slide, please. I forgot to say something. The state share of the directed payments are paid by providers. It's not funded through general funds. It's funded through provider taxes and IGTs, what I call IGTs. It's intergovernmental transfers. So for the hospital rate improvement program and the ambulance provider assessment program, those two are funded through provider taxes, which also is addressed in H.R. 1 to start reducing in 28 by 0.5%. The other thing is on the university-directed payment, the Kentucky Trauma Hospital Rate Improvement Program, and House Bill 152, which is another acronym, ASPP, Ambulance Supplemental Payment Program. Those will be funded through intergovernmental transfers. The universities pay the state share for the university-directed and trauma hospitals currently. And then in the new House Bill 152 measure, that's going to be funded by localities, local governments. The government owns will be required to make that state share. Okay. Sorry about that. Going back, I wanted to make sure that was clear. This is the waiver spin. What I'm showing here is how the waivers have grown. You can see that in 2025, the waivers grew by $247 million, and that's about a 15.4% increase. That is primarily due to the waiver rate study being implemented in 2025, as well as additional slots being filled. We had some slots, and my colleague sitting behind me here, they're going to be presenting that to you all in more detail here in a second. One thing I will point out is if you look at 2020, the total spend, and then the total spend in 2025, it's doubled in just 6 years. And I will point out in 23, you can see the large increase there in 23. That was a result of House Bill, the budget bill at that year, when we were instructed to do a 10% across the board rate increase, as well as a 50% increase for residential stays. And then in 24, we did another increase of a 10% across the board per instructions. And then in 25, that's where I said it was due to the rate study, as well as backfilling some of those slots. Next slide. So that brings me to this point. I know there's been some concerns mentioned about our growth and our budget. I'm concerned too. We've seen a large growth from 2020 to 2025 of $8.5 billion. Our budget, and that's total funds. So our budget has grown $8.5 billion over 6 years. Approximately $6 billion of those funds are passed through what I call legislative directives, which is basically legislation that is passed by the General Assembly. A lot of that is in the budget bills, but you can see the majority of that 70% is in the state-directed payments. So I will go over more in detail, but I wanted to list these things out to where I'm showing the 70%, but also $1.4 billion of the state funds, which could include restricted funds, but there's also general funds in that mix. But majority of it is in the state-directed payment, which includes restricted funds. Next slide. So just to go in a little more detail on each one of those, state-directed payments, we've added new directed payments. We've expanded directed payments. If you recall, we expanded ATRIP to include outpatient on top of when we had it at inpatient. I'm not saying it's a bad thing. I'm just saying it's added to the growth of this budget. There are other bills that's out there. I mentioned there's House Bill 152 that just passed. My understanding there are in the works, I've heard through the grapevine, don't know if it's true, but that there's works of another directed payment that is being considered that people are reaching out to you all about. So just wanted to bring that up, that it does grow the budget, regardless if it's state funds or is funded through other mechanisms other than general fund, it does grow the overall budget. Nursing facility makes up about 4.4% of the total growth. We were directed by the General Assembly in the budget bill, if you look in the 22 regular session, that we added $29 per day add-on to their rates, which we did. And then we were instructed in the 25 through the last budget bill, House Bill 6, to do the rebase, which we did. So those add to the rate to the cause of the growth of our budget. 1915C waiver rate study, I mentioned that just a second ago. We just implemented that. That adds up to about 2% of the growth, but like I said, it will probably see a much larger impact in 26 because it was implemented 1/1 of 25. So you're going to see 6 more months worth of that higher paid rate at more slots. So it's going to increase the budget.